Good afternoon, everybody, and welcome to this month's Disaster Health Response Ecosystem Preparedness webinar series. Today, we're going to discuss psychological first aid and regional disaster behavioral health operations with Dr. Jerry Walker and Mr. Paul Brantmeyer. A few things just before we begin: disclosure for continuing education purposes. Today's webinar live recording is eligible for 1 continuing education hour for physicians, nurses, and EMS providers. Today's disclosure declaration. Our faculty today have nothing to disclose, and just our planning committee, Dr. James Lawler, does have a disclosure. For today's webinar, if you could please enter all your questions in the Q&A box in the chat. We will monitor that and come to questions at the end of today's session. And then here's the instructions to access your CME certificate. You'll also receive an email at the end of today's webinar to link to that as well. And with that, we'll go ahead and start with our presenters today. We have Dr. Jerry Walker. Dr. Walker is a psychology services manager at Nebraska Medicine. He's a board certified counseling psychologist who currently works and oversees the psychology department, the chronic pain management program, integrated primary care behavioral health operations, and regional disaster behavioral health planning. He received his undergraduate training from the University of Texas and his PhD in counseling psychology and human systems from Florida State University. He then served 8 years as a psychologist in the United States Air Force, holding multiple leadership positions in both clinical and operational psychology. And today we're also joined by Mr. Paul Brantmeyer. Paul is the Senior Program Manager for NSRI Field Operations and Training. He provides operations, training, and exercise planning support for programs, including all hazards response training and other projects through NSRI and the University of Nebraska for numerous agencies. He also manages the Expeditionary Biosurveillance Research and Training Program, providing laboratory training and analytical exercise services domestically and abroad. And with that, I'll go ahead and turn it over to Dr. Walker.
Wonderful. Thank you, Lauren. Good afternoon, everybody. Thank you so much for taking the time out of your day to join us on the lunch hour and talk about psychological first aid. Lauren, next slide, please. Okay, so I don't have anything to disclose other than the fact that I'm not the kind of doctor my mother can be proud of. Lauren gave me a great introduction, but I just want to kind of add, I have the pleasure of being the behavioral health team lead for our regional disaster health ecosystem. And what that means is we are working on regional plans for how we conduct disaster behavioral health exercises and real world responses across a multi-state region. And so Paul's going to give you some more information about that later, but I wanted to kind of set the context for our discussion today. And we're going to focus starting first on the individual and kind of broaden the scope as we go along to talk about what an individual disaster behavioral health response might look like, what a team-based approach might look like, and how does this fold into our regional planning. Next slide. So here's what we're going to cover today. And I think I set these learning objectives because if you take away nothing else from this presentation, if you know how to provide safety and comfort, if you know at least a few coping strategies that you can offer to disaster survivors, then you've got the kind of the nuts and bolts of psychological first aid. It's certainly not all encompassing, but that would be kind of a bare minimum approach. For those of you who may not be familiar with this term, it's the first time you're encountering it. Let's focus on these items. But if you're familiar with this, or maybe you perform psychological first aid or PFA in the past, then let's build upon that repository of skills and hopefully add to it so that you're prepared to respond. Next slide. Okay, so what is PFA? For the uninitiated, this is a methodology for how we provide behavioral health support to disaster survivors. And this could be any number of different disasters. I think typically when we hear that word, we think in terms of sea Bernie. So chemical, biological, radiological, explosion, those kinds of events. But disaster is really all encompassing. This could be an active shooter. This could be an act of God. This could be even a freeway accident, motor vehicle accident. Disaster is really kind of all encompassing. And so when we think about the applicability of a behavioral health response to these kind of disasters, it really can fit a wide variety of both small scale and large scale scenarios. I'd like to call your attention to a few key verbiage points on this slide, just because this was a very intentionally crafted definition of PFA. This is an evidence-informed, not evidence-based approach. I'll get into that in a bit in the next slide. And it's designed to adapt to different scenarios. So the idea that not all the disasters are the same, and not all survivors' needs are the same. So we have to be able to flexibly apply a model in order to attend to what are the specific needs of the population within that context. You also note that I crossed out the word victims. Terminology can be extremely important for how we think about the needs of people in these situations, but also for how the survivors can consider themselves in the context of a disaster scenario. The word victims leans more towards the idea of external locus of control, the idea that things happen to me, it's completely outside of my control and my capability to respond. I'm essentially a sense of helplessness in that situation. Whereas survivors imply personal agency, the idea that people can, despite these things happening to them, take action and be involved in not just their survival, but in their recovery and recuperation. So I encourage you to try to use the same terminology when we're talking about our role, and as well as when we're working with disaster survivors, to use that terminology. So the goal of, or the purpose of psychological first aid is to manage the survivor's immediate distress. So we're working with them in the moment, helping them deal with their reactive emotions and functional behavioral issues right then and there. And the long-term goal is that we're going to help them cope with that, both in the hours after an event as well as a few days after the event. We're not there to actually diagnose, treat any kind of psychiatric or psychological disorder. That's beyond the scope of PFA. PFA is really focused on the here and now. What can we do for this person right here in this moment and set them up for success in the next several days after the disaster event? And so by that token, the goals for PFA is really to provide support, emotional support, safety support, social support, things of that nature. And we want to focus on how we can set that person up for coping, both in the near term and the long term. Big reason for this is because a lot of times disaster victims have not ever experienced any kind of life or death or impactful disaster like this before. They may not have a repository of coping strategies that they can readily apply to these disaster scenarios. And oftentimes people fall back on maladaptive or potentially maladaptive mechanisms for coping with stress, which can then in turn exacerbate or even compound any kind of acute stress reactions or post-traumatic stress reactions. So we want to set them up for success and help them learn how to alleviate that stress and the normal heightened baseline physiological arousal that happens in the wake of a disaster. Next slide. Now, unfortunately, there's not a lot of evidence-based research for PFA, and there's a few reasons for why that is. First, it would be very difficult to, in a laboratory approach, randomize folks to a PFA and a non-PFA condition. You think about the ethics at play where we would try to control for all external factors, and the idea of creating a potentially traumatic event, a disaster scenario, and then including some people in that in the psychological support of PFA and others not getting that. It's not really ethical and probably illegal. So we don't really have any randomized or non-randomized trials of this. The best that we have is case evidence. And this evidence comes from what people used to do in the past. If you've heard of CISM, critical incident stress management, other approaches where folks would go through a modified sort of like PTSD treatment protocol. And from this, we've followed people after these disaster scenarios and just kind of saw how they did. Looked at rates of PTSD from those survivors and kind of looked at what seems to have worked and what hasn't worked. Now, while PFA is designed as a way to try to reduce the incidence of PTSD, there's no evidence that it actually does this. And again, that part of the reason for that is we can't really control everything that you would need to in an experiment to be able to accurately predict the impact of some of these variables on the outcome. So with all different disasters being different, with the context varying between themselves, and even with the populations of people affected being different, we don't really fully understand who may go on to develop an acute stress disorder or post-traumatic stress syndrome and who doesn't. But what we do know is that certain things, such as dissociation and perceived poor social support in the immediate aftermath of a disaster, do contribute to an increased risk of developing PTSD. And so the idea behind PFA is that let's target these two specific items and do it in a calm and supportive manner where we empower the individual and unite them and create a sense of community and see if that has the best impact on not only reducing the development of psychiatric conditions such as PTSD, but promoting long-term adaptability and recovery. Next slide. So these are the 8 core actions of PFA. And I'll go through these in turn. We'll actually spend the bulk of our time today on these different actions. One thing I want to stress, though, is that this is, even though it's presented in a linear manner, it's not necessarily a stepwise process. So, while in an ideal PFA response, you would go from contact and engagement to safety and comfort and stabilization and so forth, PFA is flexible enough to where you can actually utilize any of these as may be appropriate for the person that's actually in front of you. So I'll go through each of these different steps and kind of discuss them in terms of what they are and what they might look like, and give you a few case studies where I've actually used all of these in the past. But if you want more information, the VA, the Veterans Affairs Administration, and the Red Cross actually have a lot of great resources on psychological first aid and actually additional training as well. I've included a link to the Field Operations Guide, which is a essential and comprehensive guide that gives you pretty much everything you would need to know as a disaster behavioral health responder in the provision of PFA. Next slide. Okay. Before we get into those steps, though, I just want to remind you of something that you're probably already very well aware of, and that's our stress response. Now, a certain amount of stress is normal, just kind of in our day-to-day lives. Things come up, they're out of the ordinary, they invoke a certain amount of stress on us, and they challenge us. And that challenge happens at a baseline physiological arousal level, such that our thinking patterns, our emotions change and adapt in response to that stressful event. Now, when we have a life or death situation, we have a disaster, especially something that affects multiple people on a larger scale, we're going to get more into the farther right of this diagram into the fight or flight response. So activation of the sympathetic nervous system. And what this does is it reorients our biological drive to seeking safety, seeking security, finding ways to either fight the threat, but really most of these kinds of disaster scenarios to escape the threat, to get away from it and get to a place where there is no more imminent threat of safety or threat of harm, I should say. So this is a primary biological urge for disaster survivors. It's a big part of the reason why one of the first things that we do in PFA is promote that sense of safety and comfort and help get the individual to a point of stabilization. Lauren, could you advance one for me? Okay. So if you're familiar with this Yerkes-Dodson curve, the idea is that a certain amount of stress can be good. There's an optimal level of stress for all of us where we feel energized and focused, where we work very well. Hopefully that's the level that I'm at right now while I'm giving this presentation. But at a certain high level of stress or even prolonged stress, it can get to the point where we start to experience negative health consequences. We stop thinking as clearly as we can. And when people are in this fight or flight type response, they are probably in a state more or less of distress. They're not going to be able to think as clearly or in as complex a manner as they would at a normal steady state. And so we want to ensure that the interventions that we're doing are simple. They're not complicated. They're not too cognitively heavy. They're not going to require a lot of demand from the person on a mental or emotional level because the person doesn't have that cognitive emotional capability at this moment. If they're in a state of distress, we need to do what we can that's as simple and effective as possible to move them back into a eustress situation, or at least be able to teach them the skills they need to move themselves back to eustress later on. So that's why PFA may, at the surface level, seem like very simplistic, not extremely psychologically engaging. Big part of the reason for that is we're working with folks who may not be in a state where they're ready for that, and their drive is for the kind of things that we can provide through PFA. Next slide. Okay, so the first step is contacting and engagement. This may seem relatively straightforward. I mean, it's just the idea that we introduce ourselves, right? But there's a right and a wrong way to introduce ourselves. Put yourself in the shoes of somebody who's just been in a life or death scenario. Maybe there's an active shooter or an explosion in their place of work, and they're shaken up. They don't know what's happening. They don't know if there's still an active threat against their lives. If you speed walk over to them, making eye contact and loudly introduce yourself and hold out a hand abruptly, that person may have an exaggerated startle response. They may not be ready for that. They may increase their stress, or they may not want to talk to you. So the importance of this contact engagement component and why it's first in PFA is to orient ourselves to the survivor and to be mindful of how do they need us to respond in this situation. So one of the first things you can do before you actually even engage is just to observe. Look around you. If there's multiple individuals who are affected, or even just that one individual for whom you're providing a PFA response, take a few seconds and look. What are they doing? Where are their eyes? How are they holding themselves? Do they seem closed off? Do they seem like they're open? Is their head up? Are they looking at you, and are they engaged? Are they crying? Are they talking to somebody? Is this not the right time to try to have a private conversation with them? So take all these things into account before you even engage contact. And this can actually help us triage who may be in the most need of services, who's really struggling or who's really breaking down, or who may be handling themselves well and could actually wait for a little bit while we handle those folks who really need us most in that situation. I think it's always helpful to prepare a brief script so you know what you're going to say and how you're going to say it. I like to keep titles out of things. I usually just introduce myself with my first name and let them know what I'm here for. I'm here to talk to disaster survivors, folks who just experienced this event. Would it be okay if I talked to you for a little bit? Would it be okay if we chatted over here in this corner for a little while? Is there anything that I can help you with? Those kinds of things. And a big part of the reason why you heard me ask those questions, asking permission, is because we want to put that person back in the driver's seat. They've been in a situation where they probably felt helpless, or maybe they've been made to feel helpless. We want to give them some semblance of control over what happens next. So we ask them for the permission to engage. And if they say no, great. We can just let them know, we'll be available if you want to talk to us later. Okay, next slide. All right. The next thing we want to do is attend to the individual's safety and comfort. So think in terms of Maslow's hierarchy, if you're familiar with that. What are some basic needs that this person may need met right now? Do they have water? Do they have food? Is it cold where they are? Do they need a blanket or additional clothing? Are there any other kinds of needs that they may have, whether it's medication or shelter, for example? If let's say the event was a flood and they've lost their home, are there things that we can help them start working towards, or at least in the immediate or near term, make sure that they've been taken care of? So in a large scale disaster, there may be some FEMA tents set up, places where you can get food or water for disaster survivors. These would be good things to know about before you even go in to provide this PFA response, so that you can help individuals attend to their safety and comfort needs. One of the things we want to look for too is to promote social engagement. So who are the people who might be able to also provide support to this person, whether they be other disaster responders or it could be other disaster survivors. One of the questions I like to ask folks is, who else do you know here? Maybe it's coworkers. Maybe they have friends or family members there. I like to get those people huddled together so that they can provide support to each other, or even just grieve together. Sometimes there will be chaplains who are responding to these disaster events. In the case where somebody is dead or missing, this can be a great relief to individuals to be able to talk about the loss of that person, the impact that's had on them. And while you're talking with these folks, be mindful of the possibility for re-traumatization. I had a situation where I responded to a disaster event, and survivors have been kind of huddled off to the side of the main area where this event had occurred, and they were in direct view of bodies and body parts where the disaster had happened. And so one of the first things we did was we found an alternative location to move the disaster survivor so that they weren't constantly being re-traumatized by what was right in front of them. So be mindful of those kinds of situations and opportunities to provide an increased sense of security and stability. Next slide, please. Okay. So the next thing we do, so we've introduced ourselves. We've made sure that the area is secure. We're hoping to provide a bit more sense of safety and calmness for the individual. This may be the first step to allowing people to actually start to decompress and experience their emotions. Up to this point, many people have been living in that kind of acute fight or flight response. And sometimes when that happens and when people start to come down from this, the full weight of their experience hits them. And it can seem like they spin right back up again. So they become distraught. They become extremely overwhelmed emotionally. They may start crying and have difficulty getting a hold of themselves. And in these situations, we don't necessarily need them to stop doing that. This is actually a good reaction because this person is experiencing the strong emotions rather than trying to repress them. We're not going to necessarily reinforce them by allowing the person to experience these things. So remain calm with them. Validate that it's okay, it's understandable that they're experiencing these things. And if they're starting to fixate on the situation that just happened or things that could happen in the future, so either looking at the past or looking too far to the future, bring them back to the present, have them focus on the here and now. If this is going on for an extended period of time, we may want to guide them in some physiological relaxation techniques such as diaphragmatic breathing or some grounding techniques. So diaphragmatic breathing, relatively simple. The idea that we focus on our breath work, pulling in air as low as we can using our diaphragm, muscle that sits underneath our lungs, kind of more in our stomach cavity. And you can have survivors actually practice this by putting a hand on their chest and a hand on on their stomach. So that way they're focusing their mind's attention on their breathing. You have them visualize the air coming in and out of their mouth, and then they've got the tactile stimulation of their hands, and they can visually see their belly and inhaling as they breathe, and then going out as they exhale, focusing on not moving their chest and inhaling into their chest cavity. So we want to keep that top hand not moving, the bottom hand doing all the work. As they're slowing down their breathing, they're going to start to experience more physiological relaxation, but it's not abnormal for folks in these situations to have kind of hiccup breathing or feel like they're having a lot of difficulty inhaling at first. That's okay. Let them know, yeah, that's perfectly normal. It's fine. Just encourage them to keep practicing and focusing on extremely slow inhaling, extremely slow exhaling. It's going to be harder for them, but generally we want to work on a 4 count in, hold it for a few seconds at the top of the breath, and then a 4 count out. The slower you can get them to exhale, the more endogenous relaxation you're actually going to activate. And then grounding techniques. This could be tactile in nature, it could be visual, anything that utilizes that person's senses to focus on what's going on with them right now. On this, I usually encourage people to get outside of their body. Again, because if their physiological arousal is high, that may actually, if they're focusing on that, may actually exacerbate it. So we want to focus on what can they look at that's outside themselves that gives them a good focal point. So, what are 3 things you see? How many things do you see that are the color red? What kind of things do you hear? What kind of things do you feel? The ground beneath your feet, your shoes, your clothing. Can you put a hand through your hair? What does that feel like? Those kinds of things. Now, if this person still has difficulty calming down, one of the things you can actually do, just kind of creative, is find them a social tether. This is somebody who maybe also a disaster survivor, but who's doing noticeably better in dealing with the aftermath and their own stress response. So bring those people together and they can actually aid each other. It can be helpful for some survivors to actually be the ones providing support to other people in that situation. And so there's mutual benefit in connecting the distraught survivor with the calm survivor. Next slide. Okay. Now, if you're still working with this person, they said, yes, I want to talk with you, or maybe they have some needs that need to be addressed. This is where we can start to get into some of the core components of psychological first aid. One of the first things we want to do is try to figure out what those needs are. So this is where we do a very truncated sort of interview with the individual, but allow them to take the lead on it. So this is different from how we might approach it in the healthcare industry or in the EMS workspace. We want to give folks the agency to talk about what's happened to them, how they see it. So I phrase it just like that. I'd like to give you the opportunity to talk about what happened, what you've been through, how you feel impacted by this event, and then just let them talk. You may be very curious. You may find what they tell you very interesting, or you may have additional questions. Please be mindful of your own needs and ask yourself before you ask any questions, what purpose does this question serve? Does this question help me better understand what this person in front of me has been through and what they may be needing? Or is this more for out of my own curiosity? I want to ask these questions. It can be difficult, but at the end of the day, remember that you're there to help kind of serve that person rather than satisfy kind of your own curiosity. If you have additional information about what's going on, you can certainly offer that to the person. But I tend to try not to volunteer that if the person doesn't ask. Sometimes people don't want to know, or maybe they're not ready to know the full extent of the disaster or the damage. And so, let them take the lead on that. And you can even just let them know, I've been learning some things about what happened. I'm more than happy to share that information with you if you want it. Things you can ask about are what are the physical needs? Did you sustain any injuries? Are you feeling sick? Are you feeling lightheaded? Have you had enough water? Do you need any food? Have you lost anybody? What kind of emotions are you feeling right now? What kind of feelings are you having? And if the person has difficulty naming them, You could even offer examples. Are you feeling anxious? Are you feeling sad? Are you feeling grief? Are you feeling any guilt? Guilt and shame are interesting. Some people may not expect that after a disaster situation that they've actually survived, they end up feeling guilty. It's almost a paradoxical reaction, but some people end up having that thought of there's more I could have done. There's something I should have seen. I could have prevented this. I could have saved that person. And so, not knowing that this is a normal reaction, some people don't express that. They feel like it's inappropriate, or they're even ashamed for thinking that way in the first place. And so being able to actually call that out and offer that person the opportunity to talk about that can offer some relief. And then ask them, how have you been dealing with this? What kind of things do you normally do to deal with extremely stressful circumstances? What have you used in the past that's been helpful? What have you been doing today or lately, so that you don't duplicate efforts, but you also know what kinds of things have been helpful, and that can help tailor some of your interventions further on. Next slide. Okay, so the next step is to figure out, okay, what are the most immediate needs? We want to triage and figure out what can we do for this person right here, right now, to address what's of utmost concern for them. So sometimes after getting this information in the previous step, I'll ask them, what's one or two things that you feel like you really need right now? What would be the most helpful for you right now? And so that way you're working collaboratively with the disaster survivor and getting a sense of what's most important to them. It may not be what we think is most important. They may say something that kind of blindsides us. What do I need right now? I need a hot cup of coffee. Meanwhile, they're bleeding, out through their leg, and they don't know where their family is. If that's what they need, if that's what's most important for them to feel calm and safe and secure, then that's what we go with. Of course, if it's something life-threatening, yes, we want to address the acute injury. But let the individual, the disaster survivor, take the lead to let you know, this is what's most important to me. This is what I really need right now. And then we can actually take that and tailor a plan to say, okay, these one or two things, we're going to do that right now. I'm going to, get with so-and-so to get you that hot cup of coffee. We can talk to this disaster coordinator to help you, reunite with your family. But longer term, what are some things that you feel like might be helpful for you? Are you going to need temporary housing? Are there financial losses that you're going to need some help in recouping some of those issues? Do you need to engage with your insurance company? Are we going to need to get medications refilled if you lost all your medications because your house is underwater? Do we need to start to call the pharmacies or call your doctor to take care of that now? If the person is extremely distraught or distressed, or they suffered a great loss, are there people that it would be helpful for you to talk to in the coming days or weeks? Other family members, other disaster survivors, maybe even engagement with some formal mental health or medical agencies or services. And one of the things you can do that'll be extremely helpful when it comes to planning this nature is, before you even start providing PFA, you start to take stock of what's going to be immediately available in that disaster response. So usually on these team-based responses, where we're providing PFA, there's all kinds of different other agencies who are going to be involved, other teams who are going to be focusing on the needs, the medical and logistical needs of survivors. And so start to take stock of what kind of agencies are there actually physically present at the disaster response site. What kind of things are available in the local community that might be helpful. So you can start to have some of those answers when they come up, if you can anticipate those, to the extent you can anticipate those. And if you don't know, then at least know who you can talk to, who else might be able to make those connections for you and the individual. Next slide. Okay. I've already talked about this in a few of the other steps, but this is where we want to kind of expand and reach out to the individual support network to provide them with both near-term and long-term social support. You may recall that this is one of the two items that can go the longest way to actually deactivating an acute stress response and helping to keep that individual's physiological arousal and acute trauma reaction from progressing to a full-blown acute stress disorder or post-traumatic stress disorder. And so I've already kind of covered a number of different ways that you might do this. You might look to connect other disaster survivors, either individuals who've had similar experiences and so they can relate to each other and empathize with each other. You can do the social tether. So, the strong with the weak, the individual who can serve as a mentor to the other person, connect that individual with people who they know or with friends or family members if those people were involved, or maybe even if they weren't, finding a way where they can reach out to, call or text family members to let them know that they're okay, or to let them know where they are and how to get in touch with them. And then looking at longer term community resources that might provide that additional social support for the individual. And when we're talking about these things, I always like to stress the importance of why we're doing this. At baseline, yes, it's important for emotional support and a sense of social connection. But there's also the shared grieving, the shared experiences. That come out of this that can be so powerful for helping people understand that what they're having is a normal reaction. It's one thing for us as responders to say that, and it's another thing entirely for people to hear, their own kinds of experiences and emotions coming from somebody else. It's a big part of the reason why support groups can be so helpful. And so we really want to encourage that to the extent that it's feasible and would be helpful for the person. Not to mention that, like I said, there may be some other disaster survivors who have weathered through this experience, and maybe their own personal agency is found in providing that support to others, and that's the way that they deal with these kind of stressful circumstances. So again, there's mutual opportunities for support. Next slide. All right. Beyond that, beyond just the social support, you notice that's a whole separate component of PFA, even though it is a coping methodology. We want to provide some basic techniques for how the individual can cope with the stressful experience that they just had. We can educate them on, that what they're experiencing is normal. We can, ask them what kind of physical things they're experiencing, anything along the fight or flight pathway. So increased heart rate, maybe some shaking or trembling, increased sweating, feeling hot, difficulty breathing, difficulty focusing. Maybe they're just hyper vigilant or feeling like something else bad is going to happen. We can normalize that and let them know that this is part of our body's way to try to help us survive. And look, you did that. You did survive the situation. And now we don't need that response anymore. So let's learn some ways that we can help kind of bring you back to your normal baseline. You provide them on education on one or two ways that they can bring down their own physiological arousal. I mentioned diaphragmatic breathing and grounding techniques. Those are quick and easy to learn, and you can do it in the span of a few minutes and actually lead the individual in those techniques. But you may, if you like mindfulness, if you like movement-based relaxation exercises, feel free to teach those as well. I just gave those two as an example. And then talk to them about the importance of long-term coping strategies. So when you're outside of this environment, what are you going to do to de-stress? Exercise is a great one. Typically, I encourage people who are using exercise for stress management to rely more on cardiovascular exercises rather than anaerobic activities. Why? Because sometimes anaerobic activities can mimic a fight or flight response, and we want to mitigate that going forward. And then talk to them about sleep hygiene, ways that they can identify if they're coping poorly. Maybe if they're they're overeating, if they're oversleeping, if they're over-exercising, if they're undereating, maybe they lose their appetite entirely, or if they're using alcohol, tobacco, even caffeine as compensatory measures or ways to try to mitigate their physiological arousal. Some people may do this for the first time. Other people may, that may have always been their go-to. Maybe they don't know a better way to cope other than substances. We want to try to identify that and give the individual alternatives outside of substances as ways to cope. So if you need kind of a summary of this slide, I put it down here in the red box. Educate, validate, and then advise. That's the core of information on coping. And last slide. All right. And finally, we want to link the individual with collaborative services. Sometimes I combine this with number 6, so connecting with social support, as especially when you're working with some people, they may not have social supports readily available, either in the area or on the site. And so maybe what they need is connection with other agencies or other resources that can help them, either with the logistics of their needs. So, like I said, housing, food pantries, things of that nature, or maybe other medical and mental health services. Sometimes when I'm going into these disaster scenarios, I'll start to look up, what are the major hospitals and major mental health agencies available in this area, so that I can get those phone numbers and provide them. Sometimes even call on an individual's behalf because they're not at the point where they're able to do that, and but they do want those services, so I can call on their behalf and kind of set up future appointments for that individual. Okay. So that is the nuts and bolts of psychological first aid. Next slide, Lauren. I know it's a ton. We went through a lot. So thankfully, there's a 2-page reference guide, and I actually have copies of these that I give out to my colleagues, my PFA peers, so they have it as just kind of a reference, something you can look back to. Sometimes in the moment, you can't remember all the stuff, and you're like, what am I doing again? And you can see it's broken down by the 8 main categories. I have some core components in each of those, so that you can take from that, oh, okay, this might not be helpful for this person, but this line is. This is what I'm going to focus on. These are included in that in that VA handbook, the PFA Field Operations Guide that I linked to earlier. But the Red Cross has their version of this as well. Next slide. One of the things that can be helpful too is actually this documentation template here. So I've used something like this before in disaster response scenarios. This can be helpful when there are a lot of different survivors that you're talking to. So it gives you a sense of, here's who I talked to, here are the resources I provided. And this is actually, there's other versions of this that you can actually give to the individual. So you can say, hey, you may not remember this 15 minutes from now, but here's some reminders. Here's some tips, includes tip sheets on, here's the diaphragmatic breathing technique that we talked about. Here are the mental health agencies that we discussed, and here's their phone number so you can call them later. Here are the things that you can do right now to help yourself de-stress. Here are some individuals that you can call for support, or you can go talk to if you're feeling up to it, those kinds of things. Okay, next slide. So I'll give you just a few examples of this, of how this kind of plays out, even though while we're going through it, I gave you examples of how I might frame these things. So these are real world cases, obviously not the name and image of the actual people, just 2 different types of disaster scenarios. So this is John. I first met John in a emergency department for a hospital where he'd been transported after a motor vehicle accident. He'd not sustained any physical injuries, but what happened was John had been distracted while driving behind the wheel of his car. He actually accidentally ran over a young bicyclist who coincidentally was also transported to the same ED. When I got there, I was informed that John had just learned that the bicyclist whom he'd ran over was going to have one of their legs amputated. So he's visibly distraught. He's pacing around the exam room. It's clear he's been crying, and doesn't even look at me when I first come in. So first thing I do, I introduce myself, explain who I am and why I'm there. John didn't really respond to me, just kind of acknowledged that I was another individual in the room. So then I proceeded to safety and comfort, asked him if he needed anything, any food, water. I don't think he was expecting that, but I think that message kind of communicated, I'm here looking out for you. I care about your needs. I'm here to attend to your needs. And so I think that kind of more got his attention. So after that, I invited him to sit down and take a few breaths with me. Invited him to sit first because pacing was only spinning him up. I want to spin him down, and then had him. I didn't teach him diaphragmatic breathing. I just had him take a few slow breaths with me, just to kind of help calm him down and get him prepared to be able to talk to me. He asked what I knew so far. I told him, exactly what I knew broadly about the incident. And then I asked him if there's anything that I missed or that he'd like to share. So I let him talk a little bit about his experience. I just provided some active listening, attentive listening techniques, didn't interject or ask any questions. Asked him if he was injured. He said he was fine. And then I, based on what I've observed and witnessed from the way that he reported it to me, I asked him if he's feeling any kind of guilt or shame about what happened. And that's when he broke down and we kind of talked through about some of his concerns, which interestingly were, not just about the welfare of the individual, but also potential legal repercussions. That was actually a major concern for him at the time. Okay. I encouraged contact with his primary support, which is his wife. He'd not reached out to her yet because he wasn't sure what to say to her. So we kind of problem solved that, role played a little bit, and then he was able to call her. I recommended he engage with a lawyer. He said he could do that on his own time, didn't need any resources there. And then I took the opportunity to actually educate him on what are normal stress reactions. So to validate, hey, it's perfectly understandable that you're feeling this way. Expressed empathy with them, even though I've not personally been through something like this. And then that's when I taught him a brief diaphragmatic breathing technique that he could use in the short term to help with that. And then, his response to me, well, how is that going to help, with all the guilt that I'm feeling? And for that, I actually taught him an expressive writing technique. So something he can do in the longer term to address those concerns. I offered him to follow up with a mental health referral in the next few days. He didn't really seem interested in that, but he did ask, about what to expect. And so I kind of hopefully planted the seed there for him to in the future engage there. So that's kind of what this looks like more practically. There's plenty of other examples I could give, but I think this is probably one of the best one where I actually went through all 8 steps. I did have another example. Next slide, Lauren. But just in the interest of time, I don't want to go through it fully. This was actually an active shooter in a workplace scenario. This was one of the big takeaways from this one was this was a person who was actually dissociating when I approached her. I realized that she was not, in a state where she could engage with me or wanted to engage with me. She just said she had to go to the bathroom. So I showed her where the bathroom was. I escorted her there, let her know where I would be, where she could find me later. And I want to say like half an hour, maybe 45 minutes later, she actually came and found me and said she was ready to talk. So, we don't always have to force ourselves on other folks, and kind of, the takeaway from this is meet the individual where they're at. Next slide. Again, be mindful of time. I want to keep moving on and share kind of in transition here what a psychological first aid or disaster behavior health response might look like more in a team-based approach. Next slide. So this is drawn from the concepts that we're developing for the R7DHRE, and the idea is that if we have a behavioral health team, a network of individuals, that we can then use that to create a flexible, scalable response to the needs of survivors, no matter where they are, no matter what kind of disaster we have within our quad state area, so Nebraska, Iowa, Kansas, and Missouri. And this team response response allows us to scale up or scale down, based on, again, the size of the event, the impact, and the needs of the disaster survivors. Our goal, though, is really the same as psychological first aid. We want to attend to the immediate emotional, psychological, behavioral, and logistical needs of disaster survivors, and then mitigate any kind of maladaptive decompensation in the future. Next slide. So the way we do that is through a variety of different interventions. One of the first things we would want to do in a team-based approach, especially in a larger scale disaster, is conduct a needs assessment. So, what are the needs of this population? What kinds of resources are available? How are we going to determine and prioritize or triage the survivors, and what might those needs look like? Of course, we want to provide PFA and immediate crisis intervention. Community outreach is extremely important, not just for our immediate work in PFA, but also in long-term recovery. How do we leverage existing assets in the community and community leaders to help the community heal in the long term? Having public information or PA individuals involved to provide information about not only the event, but also resources for those survivors, and then providing that care to other responders. So our fellow responders, whether they be of a behavioral health nature or not, they can experience traumatization from this kind of work. And so it's not uncommon in disaster scenarios that you're providing psychological first aid, not just to disaster survivors, but also to other medical responders. Next slide. Okay, so in a disaster behavioral team, typically you'll have a team leader. Sometimes you'll have a logistics expert as well, but failing that, the team leader will take over the logistics, and they'll coordinate the team, be responsible for training. They'll conduct that behavioral health needs assessment and look at how we're going to deploy and what how we're going to actually implement PFA with the different groups of disaster responders. A behavioral team can consist of tons of different folks, and while I've listed a bunch of people within the helping professions, they may not necessarily even have a behavioral health background. A lot of first responders can actually be and are actually trained in psychological first aid, and so they can provide these kinds of services as well. Next slide. So our concept of operation for the behavioral health team in the region follows a phasic approach. And the idea is that there's things that we can do to prevent severe disaster-related emotional and behavioral reactions for whole communities, but also things we can do to prepare for the eventuality of these kinds of situations. Our immediate response, that's where we actually have individuals going on site and working with disaster survivors. And then phase 3 would be preparing the community for longer term recovery, so longer term services and connectedness to help them in the resources that they need, both of a behavioral health nature and otherwise, to recover and repair themselves. So next slide. Just kind of briefly talk about what this looks like. So outreach and education is huge. We've been doing a lot of that throughout the pandemic, teaching folks basic coping strategies, helping them connect with other agencies or individuals to help bolster not just social support, but positive coping and enhance psychological well-being. From a standpoint of anticipatory stress and trauma experience, we can do pre-exposure preparation training. So we've done a lot of this for healthcare workers going into the pandemic. So the idea that here are the stresses you may encounter. Let's start to plan now for how you're going to cope for it, rather than waiting until it actually happens. And then at the individual level, we've been getting a lot of folks trained in psychological first aid and doing just-in-time training to prepare to deploy to these kinds of post-disaster scenarios. Okay. Next slide. So when we deploy a team, we're looking at a targeted way to in an organized manner, apply PFA to certain populations, provide that kind of just-in-time needed crisis intervention. What I've shown here on a map is the idea that, depending on where these disasters occurs and where the needs of these disaster survivors are, our teams could be deployed to pretty much anywhere. A smaller circle on the kind of the most right-hand side, looking over Kansas City, they're may be sufficient behavioral health assets, personnel, and resources there to only need to look and kind of the immediate surrounding community to call folks in from those agencies to provide that support. Let's say it was a larger scale event that happened like just a few years ago, the flooding in the Omaha and north of Omaha Council Bluffs area. Because of the scale and scope of that disaster and because of the broader region where people were affected, we may need to expand the circle and kind of look even further out to try to draw in more individuals to provide that immediate response. And then here's an area in rural Kansas. Let's say there's no major cities around. There may not be a paucity of trained individuals who can provide a response. In that case, we may look even further out, again, across state lines to try to find folks who can temporarily deploy to provide those that behavioral health response. Next slide. And then longer term, this should always be a focus in PFA is, I'm caring for the person right in front of me, but what is the longer term plan going forward? This is where we can connect with community leaders, whether that's agencies or individuals, public service individuals or agencies, to look at how are we going to support specific subsets of individuals or care for these broader needs. And this is where we as responders can say, here are some of the common needs I've been hearing in providing PFA. A lot of people are talking about food insecurity, housing insecurity, concern about education, things of that nature. We can bring those to community leaders to let them know, here are some of the needs of your community for the longer term. Then, of course, demobilization. These are temporary responses. So, preparing to go back to our normal work and then deal with our own experiences and what we've been through. Next slide. So I've talked a lot about what this might look like on an individual and a team level, but there's got to be an organization behind this to kind of leverage all of this and make it all happen. So I'm going to turn it over here to Paul. Sorry, Paul, I only gave you like 5 minutes left to talk about EMAC and how they work to help promote these kinds of ConOps deployments.
No worries. Thanks very much, Dr. Walker. And as Dr. Walker was talking about, there needs to be a system behind it all that kind of supports it because, as you talk about deploying and going somewhere to a disaster site or location, a lot of questions might arise like, well, food, water, logistics, nuts, bolts, etc. And very briefly, that is the Emergency Management Assistant Compact, which is a system that's been tried and true and tested over the last 30 years and born of principles and processes that work. And the whole concept of EMAC is to be able to provide those responders all the logistics so they don't have to worry about a thing. They can just come into the disaster zone and they can hit the ground running and do their job and be supportive. And so you might say, well, what's the eligibility? These EMAC deployments are under declared emergencies, and they cross state lines. So the articles and logistics and legalities of your license, right, your credentials, those are all taken care of and ratified by all 50 states, right, by all, and in addition to the territories. And this is also ratified by Congress, and it is a nationally recognized program, and it's searchable. Everybody is deployable through EMAC. Next slide.
And that license reciprocity is a big one. So,
yes.
So license reciprocity between states for disaster responses.
And so literally everybody, right, can be deployed through EMAC, right, and support. These are all different types of functional areas. And so one of the things that we want to make sure that the behavioral health folks understand is, next slide, there is a space for you, right? And behavioral health teams and specialists in emergency responses are not ancillary, right? They are essential and highly requested services. And that's all I got. Back to you, Dr. Walker.
Excellent, thank you. So I'm about to put this link in the chat here. If this appeals to you, you like the idea of being able to provide this critical service for disaster survivors in the region, Whether it's a declared emergency or a non-declared emergency. I'm going to invite you to sign up. Oh, look, Paul's already beat me to it. You just click on this link and enter your information, and this will strictly be on a volunteer basis. Following that concentric circle diagram that I showed you earlier, we'd be able to provide you with all information about the potential event and your role in it, approximate timelines, and then you'd be free to accept or decline as your availability or interest allows. So if you're at all a little bit interested, I encourage you to click that link and give us your information. With that, I'll conclude today's webinar. Thank you so much for joining.
Great. Thanks, Dr. Walker. Thanks, Mr. Brandmeier, for today's webinar. With that, we will go ahead and have the webinar recording posted along with the slides on our website within 3 to 5 business days. And we appreciate everyone's time today. Thank you.